So first of all, I would like to really appreciate and thank you, all of you, for joining this and taking out this time out of your busy lives, I'm sure, and just taking out some time for yourself, for studying and for learning and showing your commitment that you're dedicated to this profession of dentistry and how committed and dedicated you are for your practice, for your patients. So it's truly commendable, and I really appreciate, and I'm extremely grateful that you've chosen to spend this time with me to learn a little bit more. Maybe you already know what we are discussing today, but maybe to just dive a little bit deeper and show your persistence and continued commitment to learning. So thank you for showing that. And if just to maybe brief you with the idea of the concept of this monthly mentorship is that as you all know that I've been doing ADC from last 6 years, and that's going on the way every year the exam happens twice in a year, and we have the batches also running twice in a year. So this was a dream from long before to start something, to create something which helps the whole dental fraternity for good and not just for ADC. And because over the years I've created those bonds and friendships with my students, and I know that some of them really were committed to learning along the way, and their journey did not stop at ADC. So seeing those spirits and seeing the way they wanted to learn and continue, I wanted to create this where the journey goes beyond ADC, where the journey is for lifelong commitment to excellence and reinventing how we do and how we consider studying about dentistry throughout our lives. Because I'm sure you continue to do your clinical courses and continuing dental education programs. But what I felt was, even many years into dentistry, as we get more and more into the clinical dentistry, we sometimes lose touch with the basics and core concepts and knowledge of dentistry. So my idea is to help general dentists, specialists, anyone who's 10 years into practice, 20 years into practice, is a dental intern right now, or maybe in the final year, or just a fresh pass out. The point is, we all still need to be in touch and know the dental core concepts really well whenever we are in the clinics. So whether we are about to, or whether it's been decades for us in the clinics, our close relationship and understanding of the core dental concepts and the diversity and the variations possible in those concepts is still really important. So having a foundational knowledge will definitely give you a standing definitely from your competition, if they are also just involved in doing the clinical courses, but staying hand in hand with the core concepts of the theory, of the basis, and definitely the contemporary ones will definitely keep you ahead of all your contemporaries. So that's the basic idea of it. And I would appreciate, this is no cost lecture once a month, and it will going to happen, like, I don't know how many years I can continue from now, but as the ADC started indefinitely into the future, this is also the beginning of this mentorship, which if anyone else takes up Winspert after me, would be a legacy that it should continue without the cause for the fraternity. Every month, the commitment to learning. So this is where I'm starting. This is a long-standing dream that I'm fulfilling right now, and you are only responsible and helpful to help me actually live that dream. So what I've decided is that we'll keep it not very long. We'll keep it maybe 30 to 45 minutes. But if you at all know me from my ADC courses, if at all you know that once we get into the role and once we start talking, and if at all we touch anything else other than dentistry also, and we get into that motivation, role, then of course we can stretch it. But then again, feel free to leave whenever you want to. There is no foundation. This is under no circumstance something which is forced, something that you have to do. This is your commitment. This should come out of you naturally. This should be your calling. This is my calling, and that's why I'm doing it. And this should be your calling to learn and be with me, and that's why we'll be together. So let's hope that we can create beautiful lectures, beautiful classes as months go by, and it becomes a learning resource for all of you. And so that you can come back to it and just watch it. Maybe, for now, I haven't planned that it will be shared on the group, the recording, because I'm not sure how it may be used, misused. So for now, it is not being shared. This would be a live class only. The concept is a live class only, but the recording will not be shared. But I'll share the article and the resources that we discussed post the class on the global group that I've created, the general group. But for the recordings, I'm not sure for how long. I'll see eventually in a month or so how it organically evolves into a being of its own. And I want it to take its own journey. So I hope you do understand that. And let's see where the journey takes us. So to introduce you what we are going to do in today's class, I've decided to actually have one concept and articles to be discussed today. And I was hoping after that article, we could also just do one clinical case with 4 or 5 questions and actually discuss that. The case and the article is not linked. They're 2 very separate topics. So the beauty of it would be that we actually would cover and briefly discuss 2 separate dental core concepts, right? So I'm going to start with this article, and these are the latest guidelines and suggestions of the management of the cracked teeth, especially when they are involved with symptoms of reversible pulpitis, right? So thank you everyone who's been messaging, and now I'm looking at the messages. So thank you guys, and yes, so great to see some familiar names and so great to see some new names as well. And welcome to the class if you're new. So I can see a lot of familiar names, but anyone who's meeting me here for the first times, are there any first timers here? Please raise your hands and please say yes on chat, and it would be nice to have some new faces. I don't know, Charu, what it may help you with, but you know me, that what I believe is that what you learn, you don't even know where it helps you. So it can help you in your part 2. It can help you maybe with one of the cases that you do that spreads your name in the community. So you don't know where your knowledge is going to help you. Knowledge is that one power, that one, I think that's strength that comes for your rescue, not once, not twice, but always in your life. I think that anybody can take everything from you, but still what remains with you is your knowledge. And I think that's the best thing. Nobody can ever steal from you, and it will always serve you. So your knowledge is truly what defines you. Everything else can be created, recreated, and just, goes and comes. So, yep, let's start. And good to know that there are new people as well. And special hello to those who are seeing me for the first time. I hope you enjoy the session and would feel like coming back the next month as well. Right, and yep, so let's start with the cracked tooth. Is everyone in the room ready to learn a little bit more about the cracked tooth, especially when associated with the symptoms? And cracked tooth already has its own symptoms, which are already confusing. And then it comes with reversible pulpitis symptoms. So that's icing on the cake. The confusion gets far more deeper. So how would you manage those, whether you do RCT, whether you do your sedative linings, or you do go with conservative managements? And as you know, even with caries now these days, it's extreme bend in dentistry throughout the globe, actually, to have the most conservative approach possible. I think in the next month's lecture, I would touch on the minimally invasive dentistry aspect in terms of caries as well. So that's also one of the very important aspect, not just for your ADC, your part 2s, but even in your day-to-day practice. I would think I would say that your knowledge and your coming across as a dentist who believes in conservative approaches has a superior impact on your patients as well. When you're dealing with them and when your approach is so very conservative, they get a trust in you that this doctor really wants to save the tooth and is not just thinking of how I can maybe, you know, take it towards an RCT or a full crown or an implant, right? Because of the consumerism and everything which gets into every industry eventually. But your understanding of conservative approaches, whether it's with cracked tooth or with caries, that reflects highly on you, right? Okay. Thank you for a constructive comments here. So I would not be looking at that. Anytime you feel this is not for you, please, you can leave the class. But I would now respect and request that you do not post comments in the middle of the lecture and do not distract me and comment on me. So thank you for that. And if it's not for you, you can easily leave the class, right? You just have to find what's for you. If it's not for you, happily press the button of leave, right? Because I'm creating this community with aligning souls. I am not creating this community for negativity and destructive comments, right? So anyone who's aligned with me will definitely stay here. And you think it's not for you, then please happily let others enjoy the lecture. So predictable management of cracked teeth with reversible pulpitis. Basically, this would be the tone of the future lectures as well, staying conservative and handling situations in the early stages so that you can identify them and then manage the tooth in the early stage and prevent the greater destruction. So this study was basically done with 100 of teeth which were involved with crack, but also presenting with the reversible pulpitis symptoms. The aim of the study was to assess symptoms and signs caused by crack in teeth and to assess a conservative management protocol. As I was emphasizing, that this article and management will also focus on how you can conservatively manage those teeth which are identified, and how will you initially diagnose it, what signs and symptoms, what investigations would you conduct, which would help you identify those signs quickly, and then have a conservative management for them. So should your initial approach be radical or should it be conservative to begin with? So after conducting this study on those 100 teeth, the conclusion that came out was that if you did an accurate diagnosis of the pulp status and the cause was linked to the crack, but no other cause, right? Not from caries or any other pulpal cause, but it was actually correctly linked with the cracked tooth as the cause, then the teeth with reversible pulpitis due to cracks can be treated conservatively without endodontic treatment in about 80% of the cases. So if it's a crack and it's reversibly inflamed, then instead of going radical and doing RCT and then crowns for splinting of the tooth, if you did a conservative management with the restorations, eliminating of the crack, in about 80% of the cases, you could save the tooth by those conservative approach. So as we know that cracks and fractures are relatively common findings in your clinical dentistry, in your day-to-day dentistry, whether you're a general dentist or a specialist, not just an endodontist. And because there is so much confusion with the symptoms that present, the term CTS was initially properly, when it was defined, was an incomplete fracture of a vital posterior tooth, which was involving dentine and also possibly dental pulp. So crack is initial and incomplete fracture where the fragments have not completely separated and it is still vital, and mostly and almost in always all the situations it involves the posterior teeth, right? So they can be associated with a number of symptoms which happen together, and the symptoms can vary from case to case. So that's what makes cracked tooth really tricky to address and manage, because the symptoms can actually change and symptoms can actually vary from patient to patient. So usually symptoms are those of one of the various forms of pulpitis, which some cases also have symptoms of apical or lateral periodontitis. What does that mean? That usually when the crack happens, it leads in gateway for the bacteria to the pulp, right? So some symptoms can really be of the pressure and the dentinal tubules, but some can actually be involving the pulp and give you the symptoms of pulpitis. Usually it would start with reversible pulpitis, and then also if it extends into the PDL or into the periapical area, it could also match the periapical periodontitis symptoms, which is pain on biting, right? Your periapical periodontitis would present as pain on biting, or your lateral periodontitis, depending upon what tissue is getting involved and getting an access to the bacteria through the crack. So for example, a tooth with acute reversible pulpitis has a different set of symptoms and signs than a tooth with acute irreversible pulpitis. We know that reversible pulpitis lasts only a few seconds, comes mostly with the stimulus, and goes away within less than 10 seconds after the stimulus, right? You do not require an analgesic, it's not very severe, it's mostly mild. But the irreversible pulpitis is differentiated that it can come spontaneously, along with that it comes with the stimulus, and it also prolongs and stays even after when the stimulus is removed. It should last more than 10 seconds to be defined as irreversible pulpitis as well. And plus you may require analgesics to actually get relief from the irreversible pulpitis. It can also disrupt the night sleep, gets increased when the patient lies down. That's why the night sleep gets disrupted as well. So furthermore, cracks may also be present in teeth which have necrotic pulps. So a tooth may have a different pulpal diagnosis, like it could have been progressed to necrosis, and it still may be involved with the crack as well, right? Those that have become pulpless due to infections coming from the caries, so it can start with a pulpal infection and then the tooth got cracked, or it could actually start as a cracked tooth, maybe after a moderate to heavy filling in that tooth, and then the pulp got involved. So the journey of the crack and the pulpal involvement could start anyways. It could start from pulp and then get involved in crack, or it can start as a crack and be involved or involve the pulp, right? So therefore, there are many different symptoms and signs that may be present in teeth with the cracks, and the patient may have different chief complaints also, different presenting signs, depending upon what began first for them, right? So far, it's all making sense? Okay, so a clearer and simpler classification of progression of cracked in teeth starts as, so the most initial and the minor form of the crack is enamel crazing. The small cracks on the surface of teeth and hence the craze lines in teeth involve only the enamel, and there are no pulpal symptoms because it's only involving the enamel. So even the dentine is not involved yet. So even sensitivity kind of symptom also would not be present, right? So no treatment is required because enamel craze line is within the enamel, but it does have potential to actually progress and involve the dentine and then eventually the pulp. And that's why the regular monitoring and observation of the patient is still required. So you'll need to monitor the patient, keep them on the recall appointments, and see whether the craze line is extending, is progressing or not. So at least that kind of management is still required. Then there is a definition of crack. A crack is a defect where there is a break between two parts, but without the separation of the fragments. Hence, it's called a crack in the tooth, right? It can involve enamel and dentine, or enamel and cementum. When it's involving crown, it's enamel and dentine, or when it's in below the CEJ, enamel and cementum. So a crack may extend into the pulp space in some cases. A crack may or may not cause pulpal disease. So it depends on its direction, depends on its orientation, depends on the path that the crack is taking. It may or may not involve the pulp, right? And and also periradicular disease, because once it involves the pulp, then it becomes the reversible, eventually progresses to irreversible pulpitis, ultimately becoming necrosed, and then involving the PDL in the periapical area. So depending whether the bacteria can actually penetrate the tooth via the crack to reach the pulp space or not. So it's also about it's not mandatory that there's a crack, so pulp would be automatically involved. It may or may not. It depends on various factors, the presence of the bacteria, the load in the patient's mouth, and the direction and the access to the bacteria for the pulpal chambers, right? So it depends on whether bacteria can actually penetrate the tooth via the crack to reach the pulp space. Cracks do not require treatment unless they are causing pulp and or periradicular diseases. However, all cracks have the potential to progress to become a fracture of the tooth. So the further severe condition that happens after crack is the fracture. So crack on its own may not also require a lot of treatment unless it's involving the pulp and the periradicular tissues, because then it's become another disease and another diagnosis itself, right? But they all have potential to progress and become a fractured tooth. Therefore, they should be monitored, if at all not treated immediately, to help prevent or manage the pulpal and periradicular conditions. So cracks which are already causing pulp and periradicular diseases, they will immediately require treatment. So imagine a tooth with crack where the pulp and PDL is not involved, definitely requires observing, definitely requires a follow-up, and maybe very minimal intervention. But a crack which is right now upon observation is involving the pulp, giving you pulpitis symptom or a periapical symptom, will immediately require the treatment. Now that kind of symptomatic pulpally involved cracked tooth will be decided, what kind of treatment you require for that will be decided based on the position, direction, and extent of the crack, right? So maybe it's reversibly inflamed, but the direction of the pulp is such that it may require extraction. So the direction and extent of the crack majorly decides the nature of the treatment that you give, which is not so with your just pulpily involved tooth, right? So fracture is a defect now, which is the more severe part of the classification. It's a defect where there is a break between the two parts and the fragments have been separated already. So the crack has progressed and actually separated a tooth into two fragments, which could be equal, which could be on the crown, which could be involving the root, could have various variations, right? Hence, a fracture of a tooth involves the dentine and either only the enamel or cementum or both of the tissues. A fracture may or may not extend into the pulp space. Again, depends on the orientation of the crack, where it began. It may or may not cause pulp disease. If it bypasses the pulp may not be involved. But if it goes through the pulp and the bacteria gained access into the pulp chamber, then it may also be involving and it's reached the pulp space, then the pulpal diagnosis also goes hand in hand. So how would you diagnose that this is my crack and the symptoms are coming from the cracked tooth, or the symptoms are coming from the pulpitis, right? So what are the classic symptoms which are associated with cracks only and something which is associated with pulp, right? So the presenting symptoms are dependent on the underlying disease processes in the dental pulp and periradicular tissues that have been caused by the crack. So the result of the various definitions and attempts to classify and list the symptoms of cracked teeth is that there are many varied management protocols recommended by the author. So why do you actually need to know which symptom is linked just with the crack and which symptoms is linked with crack with reversible pulpitis, and what symptoms are linked with crack with irreversible pulpitis? When you can define and diagnose your tooth based on the symptoms into crack with reversible, crack without pulp involvement, and crack with irreversible pulpitis, then you can actually tailor make the best and the most conservative treatment plan for your patient. And the more you diagnose that rightly in the right time, the more you would be able to save the tooth from the future damage. So correct diagnosis at the correct timing and accurate diagnosis is helpful. So there is no standard management protocol to follow, and there are no studies that have followed teeth for sufficient times to be able to adequately analyze various treatment approaches that you would require. So this results in uncertainty amongst practitioners and patients. In the worst case scenario, poorly handled cases of cracked teeth may progress to undesirable manifestations of pulp and periradicular disease. If initially you miss out on significant classical just cracked tooth signs as well, and if they are missed out, then it can inadvertently lead to the involvement of the pulp, involvement of the PDL, maybe in the irreversible manner, and ultimately would require more radical treatment, right? So that's why the so-called cracked tooth syndrome is often also confused with vertical root fractures, right? But they are again separate. Crack is an incomplete involvement of the tooth, and fracture is where the fragments are separated. VRF inadvertently goes for extraction. The fragments have separated. There is no means of actually retaining and splinting those fragments together and saving the tooth for long run. So prognosis is extremely poor for VRF. Vertical root fractures, it goes below the CEJ. There is no scope to actually repair the fracture as well, or give a crown or give a full crown and provide coverage because it goes far below the CEJ. So VRF inadvertently goes for extraction, but cracked tooth syndrome should not be confused with that. Cracks are still involving the crowns and maybe some part of CEJ, but there is no complete separation, so can still be saved with full coverage crowns if required. The management of cracks in teeth should be based on the concept of a crack being a biological problem rather than a mechanical problem in the tooth. Why biological problem and not mechanical problem? Because biological problem is that it is an access way, an entry way of the bacteria into the pulp and periradicular tissues, just like your caries or a restoration with a leaking margin is a biological problem, is a mechanical entryway of bacteria within your pulp and periradicular diseases, right? So similarly, you should consider a crack is a potential cause for pulp and periradicular condition in the same manner your caries or a breaking or a broken down restoration margin can actually cause these diseases by allowing the bacteria to enter the tooth and then ultimately release their endotoxins and lead to the pulpal disease, right? That's why crack is more of a finding or a particular cause of a disease rather than a disease or a condition itself. So that's a very important statement. Crack itself is not a diagnosis, but crack is a finding or an etiology for a pulpal diagnosis because it can lead to, right? So noting the presence of a crack should be considered as a clinical finding or observation and not a diagnosis. It should be considered a potential pathway of entry for bacteria into the tooth. It's important to know that all cracks will lead to, not all the cracks will lead to pulp and periradicular disease because of their direction. And these problems will only occur if sufficient number of bacteria are present in the crack and if the particular bacteria is actually virulent enough to cause the disease or cause the pulpal and periradicular disease. Maybe it's a weak bacteria and not a pathogenic bacteria, then also it won't happen. So not all cracks will eventually get pulpally involved, but a cracked tooth may get pulpally involved. It's an entryway, right? So when they started this studies, what was the clinical presentation and the symptoms that they found in those teeth, and what was the management and approach for that? So with thorough examination, they kind of created a study for 100 teeth, which were diagnosed with reversible pulpitis due to cracks, not any other factor. So commonly reported signs of cracked teeth and pulpitis were identified and assessed. Patient reports of sensitivity to various stimuli were recorded, whether it was pain to biting, whether it was pain to cold. Then pain associated with biting was also further investigated by using a tooth sleuth, a biting technique. In particular, especially when the presence of pain on application or release of pressure was noted. Then other factors were also assessed. These included the reason for referral to the endodontist, the pain symptoms reported by the patient, the duration of the pain, again, so it should still be qualified within the reversible pulpitis. That was the case selection criteria. It should be classical signs of cracked tooth, which is either pain on biting or pain on release of bite, and also within reversible pulpitis by the duration of the pain remaining within the defined number that I explained before, right? And there was no pain after the removal of stimulus or faded away within seconds. Now, once the specific tooth had been identified and the diagnosis was confirmed, the patients were provided with a detailed explanation of the presenting problem and what was their proposed management. So the management that was allowed and that was done and which is recommended now, if you get in your practice a cracked tooth with reversible and irreversible pulpitis. So this recommended and suggested conservative management is, so when you get a cracked tooth with reversible pulpitis, the first management is removing the restoration and cracks, right? The earlier management, and if you've read from older guidelines and older textbooks, the management used to be to actually band the tooth first and then trying to remove the cracks and remove the restoration, thinking that it would be splinting the tooth together. It would protect the splitting of the crack, and it would protect the further disintegration of the crack and its progression into fracture, which is not correct, because what happens is the band will not be able to contain those forces, and you're kind of hiding the weaknesses. You're kind of bypassing the weaknesses within the tooth. That's why removing the restoration and cracks without putting the band and splinting the tooth fragments now is recommended, so that all the weaknesses, if it has to progress, if it's a weak and the line is there, so let it continue and then remove and eliminate the cracks, so that you know the remaining tooth structure is intact and can withstand the forces. So that is a big change in the recent guidelines from the older ones, is that now banding happens after removing the restoration and the crack, whereas in older guidelines or some older case managements, you would study that band it first, splint it first, and then remove the crack and restoration. So please remember, this is your one takeaway point, that you have to band later and remove the restoration and the cracks first. So once you understand this point, you've identified it's a cracked tooth, pulp is involved, but reversibly, I have to remove the restoration entirely and then identify the cracks with the visual examination, transillumination, right? Not just with tooth sleuth, because it can confuse with the periapical symptoms anyways. So identify visually with using transillumination. These days, even laser diode lasers are being used for diagnosis. So identify, visualize it, remove the crack and restoration both. And because you have reversible pulpitis symptoms, give a sedative lining which contains your steroids and your calcium hydroxide. So Ledamix is the most commonly used sedative lining. Then give a temporary restoration on top of it, and it may or may not require to give a stainless steel band. Then you would continue to reassess the patients within few days and then within few weeks. If you think the patient's symptoms of reversible pulpitis have then resolved, there are no symptoms, then you still continue to review in 3 months, because there could be two outcomes for the resolved symptom. One, actually your reversible pulpitis has healed. Two, it has then progressed to your necrosis maybe, right? So if you even after 3 months, you don't see any pulpal response, then it should raise a question that whether the pulp has degenerated and actually become necrosed. Or if you think the normal pulp test response comes back, then that means that pulpitis has been resolved. So the definite restoration will follow at least after 3 to 6 months, when you are either getting the pulpal tests which are normal, then you will give and restore with the final restoration, but still no response, and considering it may be necrosis, review again in 3 to 6 months and only give the definite restorations in the reversible pulpitis involved with the crack when the pulp tests show normal. Then you can go ahead and give an overlay or a full crown depending upon the remaining tooth structure. A crown is required when more than the cusp and half of the walls are also lost, but overlay or an onlay can suffice when the walls are still intact and only cusps are lost. If after giving the sedative lining and giving a temporary restorations, if you found that symptoms continue and they worsen in fact, and the pain is more prolonged and coming spontaneously now, so it has progressed to the irreversible pulpitis situation, then you would immediately commence the root canal treatment, right? And anytime the root gets involved, as I told you, like with VRF as well, once the root gets involved with the cracks or fractures, the extraction is required. So all this conservative management is when the crack is within the crown only, right? Or if there is pulpal exposure, there is a direct pulpal exposure either by the caries or crack, then you will have to commence the root canal treatment, right? If post is needed for crown retention, like the crack is there, the pulpal symptoms are still reversible, but the coronal structure has been destructed so much, or there has been like more than 180 degrees of tooth structure that's lost, that is more than half of the crown, if it's lost, that's an indicator for post. So how do we know how much tooth structure destruction requires post? The takeaway for that is more than half of the tooth structure lost, crown, more than half of the crown structure lost is an indicator for the post requirement. And if that tooth structure lost or any of the wall is lost till the gingival level, that means insufficient ferrule. So any of the wall lost till the gingival level means insufficient ferrule. That is an indicator for, along with the post, also your crown lengthening. So looking at the destruction of the tooth, you can actually tell what is the prosthetic treatment required. So if you start from minimal crown destruction, where there is only some portion of the tooth with the caries which is lost, you can go with a direct restoration, right? If it's a large portion of the tooth involved within the crown, then an inlay, which is an indirect restoration, that can also be given. If along with that cusps are also lost, 1 or 2 cusps are lost, then you can either give cuspal coverage with your direct restoration, like using your composite. You can actually give the cuspal coverage. That's called your onlay or cuspal coverage with direct restoration. Or you can have a lab-made onlays, ceramic onlays, which is your indirect cuspal coverage restorations. Then along with the cusp is more than cusp, the half of the walls are also lost, then the full crown is required. Now, full crown will require post or not. That is decided on whether the walls are or the total structure lost is more than 50% or not. If less than 50% tooth structure lost, just involving cusp and walls, give the full crown. But you think there is more than 50% of tooth structure lost involving the cusp and the walls, then your post will also be required with the crown, because there would be not enough retention for the crown. And when do you require crown lengthening and then give the crown? That is when any of the wall, even if it's single wall, which is going to the gingival level, that is lack of ferrule. Ferrule is healthy amount of dentine or natural tooth structure, 1.5 to 2 mm above the CEJ, which will give you the retention for the full crown. So if any of the wall is broken down till gingival level, that circle band of ferrule is missing. And to gain that, surgical crown lengthening, or orthodontic extrusion, some kind of crown lengthening is definitely required. So does that help you at least imagine from this stage of destruction, starting from the minimal tooth structure loss to the extensive tooth structure loss, actually give you an overlay of where you require what kind of restoration? I really want to know that. Did that resonate with you? Did that make sense to you? Going from smaller destruction to the greater destruction, what kind of restoration or prosthetic rehab would be required? So based on all the whatever crack is involved, that kind of knowledge and understanding by just looking at the tooth structure would immediately give you that information. What is your long-term definite restoration management? So if your initial signs were of irreversible pulpitis, no doubt about that, because eventually you're still saving that tooth. So remove the restoration and cracks before banding and start RCT. So don't wait for any sedative dressings or linings before you start treatment for irreversible pulpitis. Then give a temporary restoration or a temporary crown with a stainless steel band. Reassess in 6 to 8 weeks. If the symptom continue, then extract. If the symptoms resolve, complete the root canal filling and a full crown plus post. If the crown destruction is more than 50%, give a post. If it's not, then just give full crown. Right? And continue to review those teeth within 6 months to 3 years, etc. So teeth which did not require immediate endodontic treatment, that means the teeth which were involved with reversible pulpitis, they were given a sedative lining, which is lead mix, which is placed to sedate the pulp and help with the healing response. The teeth were then restored with a temporary restoration using your chemical stet GIC cements and depending on the aesthetic requirement on each particular tooth. Then a stainless steel band was utilized as part of the interim restoration. The band served to retain the interim restoration and not as a splint to hold the cracks, because you've eliminated the crack. So you're not using the band to splint the tooth, you're only using it to retain the temporary restoration, right? And some cases where the tooth structure was lost so much, sometime a temporary crown was required rather than a temporary direct restoration with GIC. So after giving your lining and interim restoration, they were warned about possible post-op pain and they were asked to record when their pain disappeared. So as we learned in that flowchart, the reevaluation and the follow-up happened. And based on that, either the final restoration was given if the pulp came back to normal response within the 3 months. Otherwise, you continue with the follow-up. And if it's necrosed and you do not find a definite diagnosis and it's going towards necrosis, then you would perform a definite RCT. So the learning points from this study would be that crack is not a disease or a diagnosis or a condition itself. It's a finding. It's an entryway for bacteria to actually cause pulpal disease. So any crack is a future pending pulpal diagnosis. That's why the observation, correct management, timely diagnosis and identification is really important. Symptoms can actually vary from tooth to tooth depending upon the involvement and the stage and the tissues involved, and whether the pulp and periradicular tissues have been already involved or not. So a thorough and comprehensive history must always be taken when you're developing a diagnosis. Clinical examination tests and radiographs are performed to confirm the diagnosis of pulp, root canal status, and periradicular status to identify the tooth which are involved. The cause of the disease should also be determined during the clinical examination. Further investigation of the tooth by removing all the restorations, caries, and cracks then confirm the above and allow the operator to reassess the prognosis and plan further treatment. That is why another golden point to take here is whenever you suspect cracks, your complete diagnosis will only be made after removing the restoration and then identifying the crack and then eliminate the crack and then band. Do not try to splint or use the band before removing the restoration or the crack. Now, there has been a belief that pain on release of biting pressure is a classical sign of cracked cusp. Again, that is also in the older texts and older guidelines and older case studies. However, this was not the case in this study. The tooth sleuth was used to test the biting pain, and only 8% of the teeth had pain on release of bite, right? And another 25% had pain on both application and release of pressure. But more than 68% teeth only had pain when the pressure was applied, that is pain on biting, without any pain on release of pressure. So what was believed to be the classical sign of cracked tooth, pain on release of the bite, please remember that is not in majority cases actually present. So do not go out looking for just exclusively that pain on release of bite. Your pain on bite only can easily be cracked. So if you have pain on biting on a restoration and you start thinking traumatic occlusions, high points, please do also consider crack in those situations. Do not rule out your crack from that differential diagnosis, thinking that because there is no pain on release of pressure, so it may not be that, right? That's one very other important takeaway point from here. So the so-called classic sign of pain on release of pressure cannot be relied upon to identify a crack in a tooth. The position, direction, and extent of the crack will determine whether or not there is any pain associated with biting, as well as determining whether the pain is associated with application or release of pressure. So it is also likely that the method that you use for testing the bite pressures and the direction of the biting can also determine how the symptoms will be reproduced that day in the clinic. That is why, to confirm the diagnosis of a crack, it is essential to visualize a crack in a tooth so that its presence, extent, its direction can be determined. Because if it's going within the root, all this management and all this conservative approach is of no use. It requires extraction. That's why complete visualization and a correct, accurate diagnosis is super important. So fiber optic light illumination is recommended to visualize and identify cracks. This should only be used pre-operatively during examination and after all restorations have been removed from the tooth. It is important to remove all the restorations, caries, and cracks for thorough investigation of a tooth without putting a band, right? That will allow you to fully assess the tooth, whether the pulp is involved, what is the remaining tooth structure, whether it can be restored again, what will be its long-term prognosis. All that you will only see once you remove the restoration and visualize the crack, right? So the lining of the choice was Ledamix, which contains triamcinolone, which is a steroid, and calcium hydroxide, which has extreme anti-inflammatory properties and a reparative dentine triggering properties, right? So calcium hydroxide is believed to trigger the production of reparative dentine, sealing off the pulp from further obnoxious exposure to the pulp, to the bacteria. Steroids have its own anti-inflammatory action, and zinc oxide eugenol, which also has a sedative effect on the pulp. So triamcinolone is a corticosteroid. Then there was a study which showed 70% of this agent is released from Ledamix cement within the first 24 hours of application to dentine, and the remainder is released by the end of 3 days. So the pulp usually will show the resolution from day 1 to day 3. 70% of the Ledamix effect is seen in the first 24 hours, and within 3 days, the entire active ingredients in your Ledamix have actually released their effect. So what is the importance of removing all the restorations, caries and cracks for further investigation is that the relevance is shown here, that once you remove the restoration, you expose the pulp, you visualize it, then it actually gives you the correct prognosis, long-term prognosis, remaining tooth structure, the extent of the crack, the sign and symptoms which are right now involving the pulp. So overall, it can prevent so many teeth which may have been ignored or which can further then eventually continue to progress to irreversible and may require more radical treatment. So for correct timing of removal, identification and diagnosis can save the tooth from extraction. So that's an extremely important step in your day-to-day practice, especially in operative practice with restored teeth. If you can manage the teeth, identify the teeth and manage them conservatively, you can actually save them in mouth for long. So as also discussed previously, the stainless steel bands were only given after giving the temporary restoration, not for removing the crack, not for splinting the cracks or cuts together. Bands do not prevent splitting of the tooth if a vertical crack is present and if it has not been removed. So if you just continue to splint it, but the future masticatory loads will lead to the progression and your canal can get more infected, and then further you will have to go for extraction. So it can actually complicate your treatment. So whatever worsening of the crack has to happen, let it happen while removing the restoration and while removing the cracks. Do not try to actually sugarcoat or hide the weaknesses of a crack, right? So diagnosis of reversible pulpitis should always be considered as a provisional diagnosis, which needs to be confirmed after giving the sedative lining and the temporary restoration and after a few weeks. But 3 months provides a longer time period to enable the operator to distinguish that, okay, if it's still not responding to the pulpal test in 3 months, then it has progressed to necrosis, because even normal pulp and your pulp necrosis, they both are symptomless. So if it's not showing your normal response to the sensibility test, then it can either be necrosis or you can wait for a few more weeks to revert back to your healthy pulp signs. Now, provided there has been an accurate diagnosis of the pulp status and its cause, teeth with reversible pulpitis due to cracks can be treated conservatively without endodontic treatment in about 80% of cases. Endodontic treatment may be required in some cases for the mechanical reasons, like if you require a post, the tooth has been destructed so much that a post is mandate, then an elective RCT is going to happen. Then you don't require this conservative management. So the outcome was that actually crack is a cause of pulpal disease rather than being a disease or a condition or a syndrome in itself. So I hope that was helpful, insightful for you to understand the involvement of cracks with restored teeth, and will give you more understanding of management of such cases. Let's quickly go to the case that we needed to discuss so that we can also wind up in time and you can get back to your routines. So let's see if you can answer. We'll keep it interactive. I'm not going to give you the answers, but rather let's have your answers on the chat for this question. So this is another clinical finding. Let's imagine this is a case in your clinic. 11-year-old girl with bump on the central hard palate. Can you see the screen? Is it wide enough, readable? Yeah. So 11-year-old girl with bump on the central hard palate. The patient told the surgeon that the lesion had been there for at least 1 year. Furthermore, she explained to the surgeon that initially the lesion was... So she explained to the surgeon that initially the lesion was small, but she had bitten it several times and now it has increased in size. So one very important giveaway here is that the lesion is not definite size. It is a new occurrence. It's not present since birth, or it's not an inherited lesion or condition. And it's growing in size as well due to minor trauma and biting. Her past medical history was significant for seasonal allergies. The extraoral examination was within normal limits. The intraoral examination revealed a soft, painless, red, pedunculated lesion over the anterior hard palate. So the pedunculated lesion also again indicates that this lesion is benign in nature, because your malignant lesions have indurated and spread out base rather than a pedunculated base. Soft, painless, and red could indicate involvement of granulation tissue or even vascular malformations. The location, which is hard palate and close proximity to the teeth, indicates that it's linked with your gingiva. So from your marginal gingiva or interdental gingiva, this swelling is associated with. So now, which options upon the presentation, upon the history, actually indicates that which options do you think the surgeon would include in their differential diagnosis? So mucocele is due to the breakdown of the salivary glands, right? An extrusion of saliva into the tissues. It's not even a true cyst. Location involves lower lip, floor of the mouth, where your salivary glands are present. Does the location match with the presentation of the lesion? No. So A is ruled out, right? Then pyogenic granuloma. Does the location, gingiva involvement, and the sign that it's increasing with irritation and trauma indicates pyogenic granuloma? Yes. Fibroma or fibrous epulis is another variation of pyogenic granuloma, only when it is more fibrotic. So they are clinically same conditions, but on the spectrum, your fibroma or fibrous epulis has more fibrous tissue than the granulation tissue. But they are both benign inflammatory conditions, right? Due to minor irritations, but on the different spectrum of histopathology, fibroma being more pink and fibrous and harder, pyogenic granuloma being more red and more containing more granulation tissue than fibrous tissue. Vascular lesions are usually present since birth or early childhood and are mostly bluish or deep red in hue, and they do not increase in size due to biting, right? And also present from early stages on. So D is also not a likely differential diagnosis. So is it correct to say B or C could be the presentation, and a surgeon might keep that in mind while making a differential diagnosis? So answer would be E here. Then what is the most likely diagnosis? We know it's either pyogenic granuloma and fibroma. So because it's more reddish, which one do you think it is, B or C? Absolutely correct. Because it's more reddish than pinkish, then it's B. So what is the most likely next step? Because you know it's most likely pyogenic granuloma, which is benign, and so for benign lesions, do you go for incisional biopsies or excisional biopsies? Or do you do the swab test? You do an excisional biopsy, right? So they will perform an excisional biopsy for this lesion, excise entirely, and send for the microscopic examination. So oral surgeon performed an excisional biopsy. A few days later, histopathological reports were available. Following the paragraph is from the report. Microscopic examination reveals the sections composed of highly vascular proliferation, which resembles granulation tissue. Numerous small and large channels have formed, filled with blood. That's why the redness and granulation tissue, lined by flat endothelial cells. So no indication of dysplasia, no indication of underlying malignancy, all benign changes, all inflammatory changes, So can you confirm the diagnosis as pyogenic granuloma, but not fibrosipulis or fibroma because of the lack of the fibrous tissue? Yes. So that would be our final diagnosis and answer. So pyogenic granuloma is an inflammatory hyperplasia. It's an misnomer, an incorrect term because there is no pus involvement. Pyogenic means pulpal pus involvement, but there is no infection, no pus involvement. It does not show even any granulomas as well. It is considered to be a reactive, benign tumor-like lesion which arises in response to different stimuli, which is chronic, low-grade clinical local irritation or trauma coming from your broken fillings or your poor oral hygiene and plaque. Hormonal factors can also have association with it. That's why the pregnancy tumor, right? If pyogenic granuloma is seen in teenagers or in pregnancy, that's your hormonal association. So in pregnant patients, it's called pregnancy tumor. But you do not excise it during pregnancy to avoid any complications because it is also known to be self-limiting when hormones are involved. So what you do is you wait after the delivery and see whether it self-regresses or not. If it regresses, then no need for further management. But if it doesn't regresses post the delivery of the baby, then you can excise it and surgically remove it, right? Poor oral hygiene when pregnancy is not involved. Poor oral hygiene is considered to be a very important precipitating factor. So clinically, it's a smooth lobulated exophytic lesion that presents sometimes as small red erythematous papules on a pedunculated or a sessile base, which is its stalk. It is usually hemorrhagic and compressible, can have few millimeters to several centimeters, and it typically grows fast, reach their full size within weeks or months. It is very unusual for the lesion to cause bone changes. It involves only the soft tissue, doesn't involve the underlying bone. It's mostly asymptomatic, can easily ulcerate, and also broken. So from the histopathological examination, there is excessive proliferation of vascular elements, which can resemble granulation tissue. It will be filled with new capillary formation, filled with red blood cells, and lined by endothelial cells, which is your blood vessel lining cells. So differential diagnosis includes your peripheral giant cell granuloma, which is a true granuloma, or a peripheral ossifying fibroma. If more osteophytic activity starts, bone deposition starts happening. Hemangiomas, hyperplastic gingival inflammation, or also a malignant tumor. So they are all exophytic lesions and also seen on gingiva. This your peripheral giant cell granuloma is clinically very similar to the pyogenic granuloma, right? That's why you only differentiate between them by histopathological examination, which is done after complete excision. Recurrence is usually seen in 10% of the cases, and in some cases, you may require re-excision if it recurs. So I hope that gave you some insight into the pyogenic granuloma, its clinical appearance and management. And I can happily take 5 minutes for Q&A. If you have more questions, you can ask me here. Otherwise, I'd like to thank you for being such a great audience and giving me all ears. And hopefully I'll be sharing what we'll discuss the next month as well, and the date of the next month's class. Usually would be before Christmas, the December month. And hopefully you'd love to join again and maybe learn more about newer topics. So again, in teenager also try to do conservative management, but with the elimination of the plaque and the local irritants. But still, if it doesn't regresses with the conservative plaque removal and the correction of the restoration, if there is any, then excision would be required. But in pregnancy, definitely excision is contraindicated till birth. Non-treatment, no, because definitely plaque is the causing factor. So that at least the eliminating of the causing factor is required. You have to remove the plaque. You have to perform some scaling there. See whether it regresses on its own. Observe definitely. But excise if it's not regressing on its own. But pregnancy, just continue to give the plaque removal. Let it stay there till the birth, because that's kind of an elective treatment. You know it's benign. There's no harm in keeping it. You don't want any complications in pregnancy. So just remember that, right? Thank you. I hope you gained from it, and I totally enjoyed serving you. And see you next month. I'll be posting on the group what would be the topic, what would be the date. Timing would usually be the same. And feel free to bring more of your friends if you think someone would be interested in joining these lectures. All right. Thank you so much. Have a good night or a good evening wherever you are. And I'm in Toronto, so my day starts now. And have a happy weekend.